we present to you a unique case of double optic disc pit with maculopathy. We assure that there is no financial interest in the making of the video and it is purely for academic purposes only. A 42-year-old male presented to our Vitreoretina services with complaints of diminution of vision in the left eye noticed since 1 year. On ophthalmic evaluation, the best corrected visual acuity in the right eye was 6/6 and in the left eye was 6/18 Anterior segment evaluation of both eyes were within normal limits. Fundus evaluation of the left eye showed double optic disc pits with macular detachment, that is, subretinal fluid with subretinal deposits. Retinal pigment epithelial changes over the macular region were also noted. The macular detachment, however, did not seem to have any obvious connection to the disc pits. Both eyes' disc photo was taken and the findings are as depicted. Humphrey visual fields 30-2 revealed normal visual fields in the right eye, however paracentral and superonasal defects in the left eye. Optical coherence tomography of the right eye showed no disc pit with a compact fovea, and in the left eye showed disc pit with subretinal fluid and schisis noted in the macular region. A shallow communication from the temporal aspect of the disc to the macula was also noted. The option of observation versus laser versus surgery was explained to the patient. Patient decided to go ahead with surgical management. Hence, left eye vitrectomy with ILM peeling with a gas tamponade under local anesthesia was planned. Our surgical goal was to relieve the traction over the macula and seal the pit. A standard 3-port 23-gauge pars plana vitrectomy was initiated. Core vitrectomy was done with a cut rate of 7,500 cuts per minute and a vacuum setting of 200 mm of mercury. PVD was then induced using a vitrectomy cutter from the disc as depicted. After staining the ILM with brilliant blue, peeling was initiated with ILM forceps. Finis loop was used to create ILM flaps which could be inverted over to cover the optic disc pits. A drop of fibrin glue was placed on the pit areas and the ILM flap covered on it to cause a sealing effect. 20% SF6 gas was then used to exchange with air. Sclerotomies were closed with 7-0 vicryl suture in a mattress fashion. Eye was patched with steroid and povidone iodine eye drops. Patient was advised to maintain face down position for 2 weeks to gain maximum tamponade effect. Post-operative period was uneventful with adequate anatomical success. After 6 weeks, patient's recorded best corrected visual acuity in the left eye was 6/12 with OCT reduced subretinal fluid and reduced intraretinal schisis. At 3 months of follow-up, the vision in the left eye had improved to 6/9, although OCT still showed some persisting subretinal fluid and schisis. This was, however, reduced from the previous visit. Gradual improvement was noted and hence the patient was reassured. To our knowledge, 11 cases of double optic disc pits with maculopathy have been reported, of which 2 underwent vitrectomy along with posterior hyaloid separation, endolaser and gas tamponade. These have shown promising results. Babu et al. Also reported use of scleral flaps to plug the double optic disc pits. Herein, we demonstrate a unique way of plugging the pits with ILM flaps using fibrin glue. The take-home message from this case discussion is, double optic disc pit maculopathy is a rare entity. Presence of 2 optic pits, which could be the reason for maculopathy, pose a challenge for management. In this interesting case, we demonstrate a unique way of sealing the optic disc pit using an internal approach by relieving the traction caused by the vitreous. We also used inverted ILM flap with fibrin glue to cover the optic disc pit. The post-operative results were promising and thus this technique can be tried for better management of double optic disc pit maculopathies. Thank you.